see. So let's go over what we found, what we did, and where we go from here. So all of us have three main blood vessels of the heart, one down the front of the heart, one down the left side, one down the right side of the heart. The one down the right side wraps around to the back of the heart. We knew from before that the ones down the front and left side of the heart were blocked up. That's what we saw the last procedure that was done back in 2015.
Yeah, 2015.
So that's still the same. The bypasses going to those blood vessels look great. So those bypasses are doing fine. Last time around, we knew that the blood vessel down the right side of the heart had some pretty severe blockages in them. At the time, it was around 80-90%. And they tried to open it up. They ballooned it first, and then they used a type of drill type device to try to drill out some of the calcium there. And I can't see the final pictures from that procedure. They're just not on the computer for us to see. But from the report, it was said that the artery dissected, which means it tore. And I don't know if there was no blood flow or how many nights did you spend in the hospital at that time? Do you remember?
Several days.
Several days. So in any case, what we see today is that the blood vessel looks better than at least what's described at the end of that case. There's good flow going through the blood vessel. There are a couple of areas of blockage there, which are ballpark around 70% or so. So better than last time around, still a significant blockage there. We started off through the wrist today because she had a hard time laying on her back from the last procedure. And we could do enough to take pictures, but to use the type of equipment that we need to in order to fix this 70% blockage or so, we'd have to switch to the leg, and it's a little bit much to stick two different blood vessels all in the same setting. And then there were initial concerns about having to lay on her back, which we would have to do from going through the leg. So I think, and not that this is the absolute deciding factor, but it's a birthday, and there's better places to spend a birthday than here in the hospital. So our plan for now is we stop for now. I'm going to tweak medicines a little bit. I'll give her a call. I'll give you a call later this week. I think we could take care of this and hopefully avoid the dissection thing that happened last time around. But it would be somewhat long, not long, but it would be going through the groin, probably hour and a half type procedure, and for sure a night in the hospital at that point in time. And if she can think about this blockage has been like this for probably years, so it's not an emergency to do something about it today.
So this is the same blockage from before? It's not a different one?
Correct.
Okay.
Correct. Same blood vessel, looks a little bit better than what's described from last time, but still a blockage there. Okay.
So basically we're just going to try it again?
I think so. Now, you could say they tried last time, good doctors had that happen. I think hopefully we could avoid that, but that's yet another reason just to think about things, make sure we do what she wants us to do, and go from there.
Okay.
All right.
So there's one that's 70.
Yeah, ballpark 70. It's the same blood vessel, about two different areas within the same blood vessel, ballpark around 70%.
So you think you can do a stent through the groin and then open up that blockage?
Correct.
But I thought when they did it last time, they said it was so calcified, they'd never seen anything that bad before.
It is calcified, and so that's, again, yet another reason we don't want to, any of these sort of more what I call complicated blockages, you don't want to just sort of rush in there, and that's why I think it's worthwhile to think. Now, again, I think we should be able to get it open and put stents in. We'd have to use special tools to deal with the calcium, because the calcium is still there.
Is it like new tools invented since 2015? Or?
There are some new tools invented since then. Some of it's the same, some of it's just sort of, I think we could use something to give us a little bit better support and go from there. Now, again, none of us unfortunately can guarantee anything, but I think we should be able to get it open.
Okay. Any other questions? Do you have any questions?
So it isn't nothing different from the other arteries. It's not.
No, otherwise nothing new from previously.
Okay. So you check the whole body. There's no other arteries.
The heart. All areas of the heart.
Okay.
The bypass things are still okay.
Correct. The bypasses that were, she had previously some bypasses that were already closed, and those are still closed at this point in time.
They still close.
Yeah, they don't, unfortunately, once a bypass closes, there's no real way to open
Can't do
that
nothing
back
about
up,
that.
no.
Maybe should we ask about the esophagus stuff? Can she still go?
Oh, yeah,
further
she's
with
gotta have
that?
the, you're supposed to do a stomach scope.
When is that planned?
Yeah, well, she hasn't set the date, but I'm supposed to go and see
Yeah, I'm sure
her
it is, yeah.
the middle of April.
That's gotta be.
Who's gonna be doing that for?
Dr. Mika.
Okay. So I may need to touch base with her only because if right now your blood thinning medicine that you're on can be stopped for things like a scope and whatnot. If we do stents, we have additional blood thinning medicine that you really can't stop for at least 6 months after procedure. So
Wait, say that again?
if we put stents in, we have
Mhm.
to put people on additional blood thinning
Oh, okay.
medicine, and that additional blood thinning medicine we really can't safely stop for at least 6 months after
Okay.
the stents are put in. And so
Okay.
sometimes, depending on how urgent they think it is to do the scope, sometimes we say we'll do the scope first. That way we don't have to worry about the stent related blood thinning medicine, and then we can do the stents without having to worry about juggling the blood thinning medicine.
Okay. So when were you thinking to do the stent through the groin? Like how soon?
We could do it. I minimum. I'd like to wait a week to let the body wash out the X-ray dye and
Okay.
whatnot.
But it's still something we have to think about whether we want to.
Yeah, I mean, you could make a case. So you could say, well, what happens if we do nothing? So she's probably been this way for maybe 7 years since 2015. So she's done, okay for 7 years, but you're having symptoms is what.
But
led
she
to-
feels like she's gotten worse.
Yeah, so
Yeah.
the symptoms have gotten worse. So whether we fix a blockage with stents or whether we just do nothing and treat with medicines, we can't say that we make a person live any longer one way or the other. So stents unfortunately don't extend life or anything like that. The goal, the primary mission to accomplish if we fix stents would be hopefully she would feel better, which
Yeah.
is important. We don't want to
Right.
downplay that, but it's
Mhm.
not. It's more a matter of quality of life than anything else.
Could I ask you a question?
Yes, sir.
That artery that was calcified, they, from what I understood, they tried to drill through it. What makes you think that you can get through it now? You got something different?
Well, we still have drill type devices. We may need a different size of drill than was used before to help deal with more calcium. We also have these balloons that deliver ultrasound shock waves that kind of break up calcium. You may have heard people have kidney stones sort of sit in that water bath and they have ultrasound shock waves that break up kidney stones.
Yeah, lithotripsy.
Yeah, so they have literally what's called a lithotripsy balloon that sits inside the blood vessel and sends out shock waves from inside the blood vessel, and that's been shown to be very effective.
Would you
I think
do that
my-
at the same time she's doing that, or is that like a separate procedure?
All in one,
All in one.
yeah.
I mean, just my concern, it's been 7 years. I feel like it's only gonna have been worse now. It's not gonna have gotten any better. Like I just it's gonna be even harder now than it would have been
Yeah.
back
To
into
try to fix things.
Yeah.
Look, so I don't want to sugarcoat things. Say it would be a piece of cake. It wouldn't. If it was a chip shot thing that would take 5 minutes to do, I would have said, well, we'll do it right now, and it
Yeah.
could have been done through
Well,
the
should
wrist.
she go ahead and do the scope for her thing before?
I'll
you
have to
do
talk
that?
with Dr. Mika.
Before you decide to do.
Yeah, I'll
if she-
talk with Dr. Mika and see how urgent that is. Dr. Mika may, on the other hand, say, well, we'd rather you take care of the heart first before, so that's something we'll have to coordinate. But to answer your question, I can't, say that with 100% certainty. No doctor can say with 100% certainty that, I guarantee I can get it open with a 0% chance of complations, right? So that's why I think it's important in some of these tougher cases to hit the pause button and let everybody think about things.
But that is an important artery there.
It is. It's a big blood vessel that
So
supplies.
if you could do it, it would improve her health.
That would be the goal. I think it would help with some of her breathing stuff. If you're going to ask me what's my percentage where I think likelihood of success, I'd say 80 to 90% success rate. Chances of any complications would be somewhere less than 1%. So that's low, it's not zero though.
So you've seen cases similar to this and be successful,
Yeah.
basically?
Yeah.
Okay. But I'm sure you've seen it go south too,
Yeah, I mean, this is what happened, you know, south is always relative, you know, the downside would be maybe you can't get it open, but
Yeah.
I think we would have a good chance of doing
Okay.
that. Okay.
All right, thank you.
Sure.